Okay, I'm Dr. Christine Green, and I'm currently a board member of ILADS, and I head their education committee. I've been in practice over 30 years and have treated Lyme disease specifically since 1989. In 1989, a young man arrived at my door, and he's my husband's nephew, a family member, and it looked like he was getting MS. He was having trouble controlling his right leg. He was a 30-year-old gentleman at that point, and I sent him to 3 neurologists, all of whom called me and said, "Looks like he has MS, but he doesn't. What do you think's going on? You know, we heard that he follows the Grateful Dead around. Do you think it has something to do with that?" But he was a carpenter, a real healthy guy, and he brought me a newspaper article. And back then, often this is how it happened. And he said, "Aunt Chris, do you think this could be what I have?" And it was about Lyme. It was about a survey in Northern California, which was ongoing at the time, called the Northern California Lyme Disease Survey. Described a couple patients who sounded like him, so I went to the medical literature. I found other patients who sounded like him. I called one of the authors of one of those papers on the East Coast, who essentially said to me, "You have a 30-year-old male with a degenerative neurologic condition, or you have a 30-year-old male with Lyme disease. Treat him. If it's Lyme, he'll get better. If it's a degenerative neurologic condition, you aren't going to hurt anything." And lo and behold, a month at that time of Rocephin, he got well. He fortunately, even though he's 30, returned home, and his mom made him see another doc down in Texas who put him on doxycycline for a year, which probably cinched and firmed up that treatment. Yeah, so the challenges I have faced in treating Lyme have been interesting for me. I began my practice as an integrative physician, meaning sometimes I call myself a vitamin doctor. I prefer to do the least to get the patient healthy and the least harmful. And after I treated the young man I told you about, I very quickly treated 3 other very sick patients who had been in my practice for some time because I recognized they might have Lyme. And to my distress, while I spent about 3 years sending the patients to herbalists or to acupuncturists or doing what I knew how to do without antibiotic, they didn't get well if I didn't give them antibiotic. So I thought, I'm going to enter normal medicine here. And to my surprise, it was just the opposite. By about the mid-1990s, and I now know why, I didn't know then, when I sent my sick Lyme patients to an infectious disease doctor for the more intensive treatment, because that is what I started to do, they would send them back and say they didn't have Lyme. And I initially thought I had misread the medical literature and didn't understand, so I started going to conferences. But the challenge in treating this disease is that there is what I would call a political split. I don't think it's a scientific split. I think there's a political split about what this disease is. And there is a large organization, as I'm sure you know, the Infectious Disease Society of America, which is the experts on treating infectious disease. So one would expect them to be the experts on this. They have more or less said there is no persistent Lyme. So the challenge I face is that I think that's very wrong. I think there is persistent infection in a number of patients who get bit by a tick, who are unlucky enough to get bit by a tick with Borrelia burgdorferi, the little bug that gives you Lyme, and they will not get well until you give them adequate antibiotic and adequate treatment, supportive treatment also. So the challenge is working in a system where the major overseeing organization, the IDSA, has said a disease doesn't exist. If they say it doesn't exist, and I prescribe doxycycline for 6 months instead of 1 month, often insurance says, well, we won't fill it because the IDSA says what you're treating doesn't exist. That's the biggest challenge, how to take care of patients when the scientific argument is pushed to the side and you just ordain what's going on here. I have a patient who, when we did the intake, she said, "Can you believe it? I was laying on the grass in Lyme, Connecticut." And interesting story, her whole family was in Lyme, Connecticut. Her husband got a known tick bite with an EM rash. One of her daughters got a known tick bite with an EM rash. She got nothing, but over the next few years, she got very ill. She got MS and began to deteriorate badly, so that she was having troubles with movements in certain limbs. She had paresthesia, which is numbness, tingling, sometimes pain in some of those limbs. She also had things that we don't always associate with MS. She was exhausted. She had brain fog. She ran several boards. All of a sudden, she had to resign. She really couldn't keep doing what she was doing. And we worked with her and with her MS doctors, who were very, very reticent to have her do this. But she was a pretty firm person. She did her research. She felt better when we gave her oral antibiotic. And she's all better on IV antibiotic. She's back to all her work, raising her kids. And it took, in her case, it took about 1.5 years, I'd have to pull her chart, of IV before she was really without symptoms. Right now, I think the biggest challenge is getting funding to actually study the disease. There is a large group of patients who have never been studied, and these are the patients who don't see a tick. Unargued in the literature, 3 to 26% of people see the tick. So how many get the rash? About 50% maybe will see a rash. So you have a large group of people, if 300,000 people a year in the United States alone are getting Lyme disease, as the CDC just admitted, then there are many of them who never associate their symptoms with the possibility of having been bitten by a tick. Everyone thinks, one, they have to see a deer in their backyard. They don't. Mice, squirrels, on this coast, squirrels carries the tick into the yard a lot. And two, they just don't think about it. They, get sick in July. Maybe they get sick enough, maybe their head hurts so much that they go and see their doc and they're told they have a virus, even if no one around them has a virus and we're out of the viral time. So the biggest challenge is in looking at those patients who have contracted Lyme, didn't know it, and are sick, getting sicker and sicker over the next few years. I, as a doctor, need to know what to do with them. I need to know if I take 100 people and I put them on this antibiotic because they have Lyme plus maybe 2 or 3 other infections the tick gave them, how long do I need to do that? What do I look for as an endpoint? And that we have to do in studies. We just have to do that in studies. As I understand it, though I may be dated a bit, I think NIH decided no more treatment studies were needed in Lyme because we understood it. So if you won't even look at the problem, if you won't even say, these people are sick, okay, if they don't have Lyme, let's figure out what they have, let's at least do a study, and let's, if it looks like they may still have Lyme, let's set up a study to find out if that's true. So I think the biggest challenge is knowing what to do with the very sick people we have in the country. There's a flip side to that. If we admitted that most people don't see the tick, that maybe 50% get the rash, and remember it can be in your hair, so they don't see the rash, then, and it's been found in 49 of 50 states. So it can happen even in my backyard here in California. I don't have to be on Cape Cod to find a Lyme tick. Then we would also diagnose this early. So another challenge, I think, for our population, for our public health, is to really recognize this up front. If we recognize this up front, we're given a month of doxycycline. We aren't giving a year of doxycycline. The training program is a genius idea. And I don't even know who came up with the idea. Maybe it was Dr. Harris. Because when I came into ILADS, the training program had just been established, I think, the year before. So it means that we can fill a void of education about tick-borne diseases. Because, as I said kind of at the beginning, I think there's this political disagreement. I even feel stupid saying that. I mean, in medicine, you really should have clinical science and laboratory science kind of guiding your way. But because there is that disagreement, many students, medical students, come out of med school not knowing anything about tick-borne disease. And so what the training program does is it lets us take a doc who's interested, who maybe has seen sick people in his practice and has related it. Maybe someone came in with a tick and then got the disease that everyone else had. I mean, and let them see how we approach it. It gives us the opportunity to give them medical data, to give them papers and information and things that they can follow up. And it's also, for me, it's fun. It's kind of like going back to med school where you did work in teams and you did, do a little bit more collaborative type of medicine. One of my patients came in once, maybe this is the way to say it, and it was a new intake, and at the end she said, "Oh, I found a medical nerd. This is what I've wanted. I found a medical nerd." So I think I understand what she meant. I am fascinated by life and the human body and kind of what gets it and what doesn't get it, and how to balance it so we feel healthy. And in that sense, I think I picked a good, career for me to do. So it's, if I have someone here observing me, I am going to really think carefully I mean, I always do. I always take care of my patients. But how can I explain to this person what I'm doing? Why? What's the process in the body that's going on, that's being disrupted by this tick-borne infection? And how can we both get rid of the infection, but also kind of correct that process? And that requires me to go to medical literature, requires me sometimes to go to basic texts. A few years ago, I went back and got my pharmacology. Well, I updated my pharmacology text and, have been looking at some basic pharmacology. So that's very gratifying, getting to know someone else who's interested in being a medical nerd, and chatting about patients. And also, patients should not have to fly to see me as a doc to get treated for Lyme disease. It's absurd. There's plenty of Lyme all over the country. There are plenty of docs all over the country. So it's also gratifying that I then get to know someone in Southern Oregon who I can send people to, or I know someone in Seattle who I can send people to, or the Midwest, or the Southwest. So I guess those are all gratifying things about it. It somewhat validates what I think I'm seeing, understanding about a process. There's a superb medical group. I mean, ILADS is full of people on a board who I believe none of them get paid and work their little tails off to really make things happen in terms of disseminating real information about this disease. So there is the support of my peers, which this does for me. I meet new docs, sometimes docs who are starting out, and that's kind of fun. And as I said, I think my patients benefit because they can be treated without having to come and stay in a hotel. So. Well, one of the things we've talked about in terms of the training program is that we need a follow-up. Someone comes and trains for a week or 2 weeks, and then goes back to their office. And Lyme is a complicated disease. The patient presentation can be very complicated. It can be a mess. I've found brain tumors in people who thought they had Lyme. And so we have talked about having a network of physicians, say, or practitioners perhaps is a better word, that might once a month have a session where we just discuss patients and discuss. I've even thought, let's have a journal club, a virtual journal club where you get to discuss a paper that one person would present. And so by expanding the program, I think what could happen is we would have a network of practitioners who provide care to patients locally in their vicinity. And I learn from the people who sit with me. They come with their own training and their own ideas. And the way that I approach medicine is very process-based. It's very, as I say, basic science. I think of what's going on in the body and what processes we need to nudge to be better in one way or another. And so other docs, as they come in, will say, oh, this person looks to me like they might have gamma globulin deficiency because I have, a patient with immunodeficiency in that way. And so sometimes I say to patients when they say, should I go get a second opinion? I say, the more eyes looking at you, as long as they're really considering the situation, the better. The more information we can get. So it could, if it expanded and became kind of regional hubs of training, I think it would be very good for patient care, very good for research. We could start doing research with this kind of crowdsourcing research that some people are starting, and maybe get rid of the disease. Wouldn't that be cool? So, for more information, contact ilads.org, ilads.org.